Welcome to the sleep apnea. So this is going to be a quick overview of the respiratory sleep apnea part of things. And so remember, there's this whole section of respiratory care you can get into, which is sleep diagnostic studies. Big area. There's credentials. You can get a special credential from the NBRC for as a respiratory therapist. You can get your sleep diagnostic specialty credential. So that is something that if you want to go into sleep studies, if that's some area that interests you, which it is very interesting to me at least, that's something that you could look at getting. RTs are also qualified to take, as of recording this, the RPSGT, so a registered polysomnography technologist exam or credential as well. So sleep studies is a very big area, and it is growing out there, and it's a very important part for us to look at, especially when we start looking at obstructive central or mixed sleep apnea. So let's get into it. So sleep apnea is sleep-related breathing disorders characterized by abnormal breathing patterns during sleep that include obstructive sleep apnea, where the airway just collapses on itself. So that way you cannot, or the airways cannot get gas to flow in because there's something obstructing the airways from gas to flow in. Central sleep apnea, which is where your brain says, don't breathe. So this is where your brain decides to turn off the signal to breathing, and we'll get into the reason why that's there as well. And then there's a combined, or also known as a mixed sleep apnea, where you have both central and obstruction going off sort of at the same time. And we'll talk about how usually with a mixed sleep apnea, and I'll preview it here real quick for you. Mixed sleep apnea usually starts as a central sleep apnea where you don't have a brain signal to breathe and you don't have diaphragmatic effort, so it's a central sleep apnea, right? The brain doesn't signal the abdomen, you're not breathing. And then they go from a central to an obstructive. So then their brain says, oh, you need to take a breath. And so it tries to take a deep breath, but the airways are obstructed now. And so that's what makes it a mixed. It starts off as a central, and then it goes into an obstructive, and then they ultimately come out of it. So mixed sleep apnea is both central and obstructive together. But remember, in that sequence, if you're looking at the mixed sleep apnea sequence, and hopefully we'll go over it here, you're going to see that the area where the brain stops, where you don't see diaphragmatic movement, you don't see airflow, and then you'll see abdominal movement, but you still won't see airflow. So that's a sign that you went from a central to an obstructive, which means both are present. Therefore, it is a mixed sleep apnea. Now, if that was too much for you too soon, that's okay. All right, I was just trying to preview it for you a little bit there. And then there's sleep-related hypoventilations or hypoxemia syndromes that are out there. Now, don't throw that last category off, that sleep-related hypoventilation or hypoxia syndromes. People with things like COPD that have a hard time getting oxygen into their bloodstream in the first place, when they go to sleep, do you think that your oxygen levels are really good and really strong when you sleep, or do you think they drop a little bit? And for almost everybody out there, your oxygen levels probably drop a little bit when you sleep. And so when you already have a hard time getting oxygen into your bloodstream, imagine if you had COPD and you had a hard time getting oxygen into your bloodstream at baseline, right? Let's say emphysema. And then you try to go to sleep. Do you think your brain is going to tolerate you being hypoxic and hypoventilating? It will not. Your brain and your heart will not tolerate hypoxemia and cyanosis. So will your brain let you go into the deep stages of sleep where you're more likely to have issues with oxygen levels? No. So a lot of these people with chronic oxygenation issues are going to have a harder time getting better quality of sleep because of their hypoventilation issue, because of their hypoxemia issue. So don't throw that out. Just because someone has COPD emphysema, that also could mean that they might need something like a sleep study to see if we can't help optimize their daily life. Because if they're not getting good quality sleep, just like you're not getting good quality sleep before exams, it's going to be a bad situation continuously night after night after night after night. Right? And so they're going to have a poor activities of daily living. They're going to be tired all the time. They're going to be grumpy, right? They're going to have some issues. So don't throw that last point off, right? Sleep-related hypoventilation, hypoxemia syndromes. Be aware of things like COPD and what that could mean for someone's sleep habits. So this is the picture from your book, and this is just trying to show obstructive sleep apnea. This is when the muscles of the throat sort of fall and tend to collapse on the airway during inhalation, right? Because remember, we're generating negative pressure in the trachea. We're generating negative pressure in the lungs to pull gas in. Well, that negative pressure also can pull the muscles backwards and against the walls of the airway. So that means the airways can collapse while the patient's trying to breathe in. So most commonly it's the tongue. I'll repeat that. Most commonly it's the tongue. I'll repeat that one more time. Most commonly it is the tongue that moves into the oral pharynx and will obstruct the airway. That's why when we go into oral devices like we do with the oral airways or the nasal pharyngeal airways when we get into critical care techniques, those are devices to help move the tongue out of the way or to keep the airway patent. Now obviously we're not going to jam one of those in someone's mouth, but a lot of the things that we do are to stent open with obstructive sleep apnea, to stent open their airways. Whether it's a stimulator device like you see with the Inspire thing, like go and YouTube Inspire or go to their website. They have like a little electronic stimulator that causes muscle contraction that someone could just it coordinates with their respiratory cycle and it coordinates with their breathing, and so when they go to sleep they just turn on this device and it keeps stimulation of these muscles almost like a TENS device. It keeps stimulations of the muscles so that way the airway stays patent during their breathing and they don't have to wear CPAP. They don't have to wear an oral device. They don't have to wear something that keeps their mouth or their tongue propped off of their tongue. So it's pretty cool. But that's usually one of the big thing is the tongue collapsing on the airway. And that's one of the reasons too why positional therapy, and I know I'm jumping ahead a little bit, but remember, the repetition is the key to learning. When you have this patient lie on their side, now this picture has them laying supine. Now let's imagine for a minute you lay down flat right now, right? If you're laying down flat, your tongue, if you go into a deep relaxed state, has more of a propensity to follow gravity and collapse down, especially when you're using negative pressure to breathe. So now roll over onto your side, whether it's right side or left side. Roll over onto that like fetal right side recovery position or left side, right? So roll over to that side. Now if the tongue relaxes, will it obstruct 100% of the airway, or will it only restrict or obstruct, will only obstruct part of the airway, right? So this is why we have them sleep on their side. There used to be a therapy called the tennis ball therapy where we'd have someone sew a tennis ball into the patient's pajamas so that way they wouldn't lie supine. They would lie on their right side or the left side, and that would actually help the airflow get into their mouth, especially if they were uncompliant with CPAP or uncompliant with all the other devices. So positional therapy can help too. I remember I had a patient that was sort of end of life, and she started having that tongue obstruct the back of her airway, that sort of snorous tongue obstructing the back of the airway noise. And I had a discussion with the care team, and the nurse was asking like what they could do about the noise. I'm like, well, I could put the patient on a CPAP, I could put them on something, but that's not something that they wanted. And so I said, well, the other thing we could do is just sort of roll them onto their side, and that sort of keeps the tongue from obstructing most of the airway, and that should help reduce the amount of noise that's at least being made. And so they were like, no, they look comfortable, and that's fine, right? And then I walked through like maybe 20 minutes later back through that unit, and sure enough, that patient's lying on their side, no sounds coming from them, and they were breathing still at that point. So just little things to look at, but the big thing here is finding ways to get the tongue from getting off of the wall of the airway. So that could include CPAP, that could include that stimulator device, that could include positional therapy, right? And we'll talk about all those different things. But I wanted you to sort of see the visual and sort of experience that too. So you can sort of see why lying on the side might be better for letting the tongue not obstruct the airway as much as if they're supine like this picture. So when we're looking at these categories of sleep disorders all together, there are way more sleep disorders than what we can cover in this class, unfortunately. And a lot of RT bachelor's programs, a little plug there, have a sleep track to them. So you can actually go into the insomnias. You can go into some of the other things, the parasomnias, the circadian rhythm disorders, sleep rhythm movement, PLMs, like all these other things that can happen during sleep. It's very intriguing. So if it's something that you think you might be interested in, especially if you're going to get a bachelor's anyway and you don't already have one, that might be something, as even if you plan on doing sleep medicine, looking into something like that, an extra sleep track, because currently the program does not have unlimited time to go into the deep sleep areas. Pun intended. All right, so there's other categories besides sleep breathing disorders, but we're going to focus on just regular sleep breathing disorders for our purposes. All right, some definitions. Apnea means the cessation or almost complete cessation. So that means that there's hardly any gas flow going through there. We'll still count it as cessation, right? When the adult airflow is less than 10%, that means almost no air is flowing past that tongue, right? For at least 10 seconds. So the important part of that is the 10 seconds. I'll repeat that. The important part of that is the 10 seconds. The important part of that is the 10 seconds, right? In apnea, 10 seconds, right? Those two should be in your brain, right? Repeat that, right? Apnea, 10 seconds. Apnea, 10 seconds. So either a complete obstruction or near complete obstruction, right? 90% obstruction is still, they would consider apnea. OSA is obstructive sleep apnea. So this means that no gas is flowing through their nose, right? And what we do for a sleep study is we'll put these little transducers all over. So if you go to that previous picture on the previous slide, or rewind the YouTube clip a little bit there, you'll see we put all these sensors, all these leads, at least 17 different things on the patient, and we're looking at all these different things simultaneously during a high quality sleep study. And when we're looking at this, one of the things we look at is gas flowing into and out of the lungs, right? So airflow. So what we'll see on there is that if their airways closed off, we'll see their abdomen moving because we have something around their abdomen. We have something that looks at their respiratory motion, right? So we'll see movement, right? Ventilatory effort, but we're not going to see any gas flow. So in other words, it would be like staring at someone and you see their belly moving, but no gas is going in and out of their lungs. Something's stuck in their throat, right? That's the same thing here, right? You're going to see their belly moving because they're trying to sleep, so it's more belly than chest. You're going to see their belly moving, but you're not going to see any chest rise. You're not going to see any movement of respiratory organs at all because there's something that's blocking the way, and usually it's the tongue. So obstructive sleep apnea means there's no airflow, but we got respiratory effort. Central sleep apnea means we don't have either. We don't have respiratory effort and we don't have airflow. So if you're looking at someone and you don't see their belly moving, you don't see their chest wall moving, and you don't see any gas flowing in and out, that's a central apnea. There's no signal to breathe there. So they're not breathing. And so that's a central sleep apnea. Now, mixed sleep apnea, MSA there, is a period of time where there's no ventilatory effort, like we talked about this before. This is it starts off as a central, where there's no respiratory effort and no gas flow. And then, after that sort of subsided, they go into an obstructive episode, where now their belly's trying to pull in a breath, but their airway is obstructed by their tongue. So they have a central followed by an obstructive apnea. So mixed sleep apnea is a central followed by an obstructive. Another definition, hypoventilation. Usually this means their CO2 is greater than 55 for at least 10 minutes. And one thing they might have you do in the hospital is do a morning blood gas on a patient that's quote unquote perfectly healthy. And what they're looking for is if they might have a sleep sleep-related breathing disorder. So that's one of the things you might do a morning blood gas and see if they're hypercarbic. If their CO2 is over 55, that actually might indicate they might need to go on assisted ventilation at night, and actually might help diagnose them, might help qualify them for CPAP and or non-invasive ventilation at night. So you might have to do that in the hospital, and that's, it feels cruel to go sticking people right after they wake up, but they'll wake up after that, that's for sure. If they're really hypercarbic, they won't wake up after that, and that's a bad sign. So the fact that they might have a strong reaction to it is a good sign. Shane Stokes breathing, we talked about this in pulmonary EMP. This is that whole Bob Ross pattern where you have an apnea, right? Remember, you have that just straight apnea, and then progressive deeper, faster, deeper, and then back again, and then apnea, right? And that's that Shane Stokes breathing pattern. Usually you're going to see apnea that surround it, and this is also something that can happen during REM sleep, so just be aware of that. The NICU, if you guys get to walk through NICUs, that's if you have permission to, then that's something you actually might see on the respiratory monitor for some of these babies in the NICU, is that Shane Stokes breathing, because they spend over 90% of their sleep cycle in REM sleep, and this is a pattern that can also occur during REM sleep as well. So Shane Stokes, that's what we're talking about here. Usually it lasts for about 40 seconds. That's what we were talking about in that 40 seconds or so. They must have at least 5 of these apnea periods that are going on here, right? They also will have hypopneas. That just means the breaths are shallow, so that would be like the bookends here. So that's a hypopnea, right? A very shallow breath. And that's what you're looking at, that crescendo, decrescendo, if you're more musically inclined, there's something for you. And hypopnea means your airflow is decreased 30% from baseline. So that's where we were talking about how they have these transducers all over these patients. Lots of good Google image search sleep studies, and you'll see a bunch of tracings all over these patients, a bunch of leads all over these patients, and one of them is airflow. And if we detect the airflow is dropped by at least 30% or more, then that means that it's a shallow breath, right? So that's something we're looking at. So be aware of the definitions. They could come into place on like a final. More definitions. There's the apnea index. These are just things that you might see out there. So I'm trying to help you familiarize with this stuff, especially if you're interested in going into sleep or doing sleep as part of a clinical. I think it's very interesting. I think it's great to sort of just see what all is out there, even if you plan, and I think especially if you plan on, especially if you don't plan on working in sleep medicine, I think it's actually more valuable for you to do a clinical at least one night, or scoring them during the day, a part of that in the sleep lab, just to sort of see that area of medicine, just to be more familiar with it, just so you have that experience under your belt, so you sort of understand what the patients go through for this whole thing. So it just makes you that much more of a compassionate and better provider overall. So the apnea index is the total number of apneas per hour of sleep. So that's something that we score, because we'll get this huge tracings, and we get, like I said, at least a minimum of 17 tracings, and it's called a montage ultimately. But we get all these tracings, and then we can score them. We look at how their eyes are moving for REM sleep. We look at their EKG. We look at their nasal index. We look at their EEG. We look at all these different things. We look at their muscle movement. We look at all these things together, and we score them, and the apnea index is one of the scores that we do there. The AHI is the apnea hypopnea index, and that one's used more commonly than just the apnea index. This is the number of apneas and hypopneas per hour of total sleep. So this is something, on average, how much do you hypoventilate or not ventilate per hour, right? And so this is something that we can look at sleep breathing disorders. Other things we'll look at, and you'll do this one more commonly in the hospital as far as like a bedside therapist, is oxygen desaturations. We'll put a continuous pulse oximetry that records things overnight on a patient that has COPD, just to see if they have oxygen desaturation saturation? And if they do, how bad is it? So maybe they qualify for a formal sleep study, or maybe they qualify for more oxygen at night, right? So oxygen desaturation is something that you might actually be doing more commonly at the bedside in acute care medicine if that's where you want to work. This is how long the desaturation falls per hour of sleep. Usually it's got to be more than 3% per hour of sleep. And so this is looking at how much they desaturate and how significant that is. So that's something that you guys will be doing. It's called nocturnal oximetry studies, and that's something that they even do for people at home. They wear pulse ox at home, and then they sort of record it and look at it. We even do this with premature babies. We'll send them home with oxygen, and then as we're looking to titrate that, we'll sort of relieve that. We'll have them record a full night's sleep, and then they'll come in and see the pulmonologist or whoever that will interpret it from there. RERAs, respiratory effort related arousal. So this is something that I was talking about a little bit ago. So this is where you have respiratory patterns that have a duration of at least 10 seconds. So the patterns characterized by increasing respiratory effort or flattening of the nasal waveform followed by an arousal for sleep. In other words, they don't meet the criteria for apnea, but it looks like there's respiratory effort related to arousal. That's where it gets its name, respiratory effort related arousal. In other words, their breathing pattern changed, and then their EEG, their brain waves, came into a more awake brainwave state. So that's one of the things we look at is their EEG, their brain waves, and we look at how deep of a sleep they're in and their brain waves, right? That's one of the things that we look at. So if we see the respiratory rate change and we see their EEG come to a lighter stage of sleep, almost to a semi-awake state of sleep, then that's a RERA. That's a respiratory effort related arousal. And these are more related to respiratory difficulties. These are more commonly seen in people that have obstructive, like pneumonia going on or anything like that. So let's start with obstructive sleep apnea first, then we'll go to central, and then we'll go to mixed. So obstructive sleep apnea includes apneas, hypopneas, and RERAs, respiratory-related arousals. So these are usually a collapse of the upper airway during sleep, right? And that's one of the big things that they talk about with some of these patients is their quality of sleep is going to be very, very poor, and their ability to mentate, right? What's your ability to mentate? What's your ability to think clearly after you get a very, very poor night's of sleep, right? So that's something that we got to consider with these patients too. Could they have better activities of daily living, right? We talked about people with emphysema or obstructive pulmonary disease, how physical activity and activities of daily living are very important for them. But if they have an issue where they can't get into deep sleep, their brain can't restore, they can't think clearly, they can't think straightly, how do you expect them to remember what medicines to take or what doctors to go see, or how do you expect them to feel good enough to go for a walk, right? So this all plays into total care of your patients, whether you're working in sleep medicine or acute care or subacute care or home care, right? It doesn't matter which areas. All of this information will pan together to help you be that much better practitioner for your patient. So this is one of those areas where you just got to be sort of cognizant. Do you have a patient that has respiratory difficulties? How's their sleep doing? All right, could we optimize them? I remember I had a patient not too long ago before I retired from the bedside, and they were diagnosed with obstructive sleep apnea, and they used a CPAP device at home. And this was like day 5 in the hospital, and they had a pneumonia. And I texted the doctor, and I said, "Hey, Dr. So-and-so, I'm Derek with Respiratory Care. I'm taking care of patient so-and-so, right? And they have a diagnosis of OSA, and they wear a CPAP at home. What are your thoughts of them wearing one while they're in the hospital?" And this patient wasn't doing so well in the hospital from many different aspects. And so the doctor said, "Yeah, that sounds great. So let's address that." And so we came up with a plan and got that patient back on some CPAP at night. And so we were able to get a mode that sort of titrated appropriately for that patient. And the next day, that patient was day-night different. She was much more interactive, much more awake, much more I want to say pleasant, but I shouldn't, but much more interactive in a good way for us as well. And so little things like this can make a big difference overall, not only in the health of your patient, but in the physical health of the patient, but also the mental health of your patient too, and the staff around that patient. During obstructive sleep apnea, obstruction commonly usually happens, and they look very quiet. It looks like they're holding their breath, and then you're going to see their abdomen start to move more and more and more. So if you're there and you're looking at their respiratory effort, you're going to see their belly start to get bigger and bigger and bigger efforts to breathe in. And usually the effort will end after an intense struggle, and some people will even wake themselves up here, which is pretty interesting. And that's one of the questions. If you look in your resources where I post the links to these, you'll see the stop bang assessment score. You'll see a couple of different sleep scores, and one of them asks, I think it's the Epworth Sleepiness Scale, asks, do you ever wake yourself up with your snoring or breathing? And that's one of the things that you look at, is they might actually, their brain is saying, we can't breathe, we're not getting oxygen, wake up. And so their brain tells them to wake up, and then they're after that intense struggle, and they really can't get that good sleep. So in severe cases, they'll wake, sit right up in bed, gasp for air. They'll feel chest pain a lot of times. Right, all these things can go along with this. Sometimes they think they just had a nightmare, right? Usually the breathing patterns are normal when they're awake, like they don't have Shane Stokes or anything like that when they're awake, but when they're asleep, that's when they go into this whole thing. And here's the thing, they don't get good quality sleep because of this, right? You see that meme to the left, right? They don't get good quality sleep because of this, and so that means during the day they're going to nap more often, and then they're going to have an issue where their naps aren't deep sleep either. And so then they go to night, and then they're not as tired, and then they're going to have issues just the same. So it's this constant vicious cycle. It's very sad. All right, there, you see the picture on the left there, the Pickwick Papers by Charles Dickens. Very good thing to look at, especially if you do sputum bowl. Right? So when we're looking at obstructive sleep apnea, a large number of patients with obstructive sleep apnea demonstrate what's called Pickwickian syndrome. So take a wild guess where Pickwickian syndrome came from, right? It was a character in the Charles Dickens, the Pickwick Papers, the Pickwick Club, way back when, and then there was a character in there, and it was Joe the Fat Boy, right? That's what he did. And this patient snored, or sorry, this individual snored and had excessive daytime sleepiness, included many classic features which now recognized as sleep apnea syndrome with hypercapnia, or OHS, obesity hypoventilation syndrome. So if you're out there and you see someone's diagnosis say OHS, that's obesity hypoventilation syndrome, and it's something just to be aware of, especially if someone has a very high BMI. This is something they will look at. They also look at things like the neck circumference. So under the resources tab, I put all three of those. I think I put the stop bang assessment, the excessive daytime sleepiness, or the Epworth Sleepiness Scale, and I think I put a third one in there. And all three of those are different ways to score someone's probability of having a sleep disorder. So I encourage you, and I think it's fun, right? It's not something I'm going to require of you here, is to go and score those. See if you have a propensity, or see if someone around you has a propensity for a sleep-related breathing disorder. And so that's what all three of those things look at. One of them just looks at excessive daytime sleepiness. One of them looks at specifically, I believe the stop bang score looks specifically at obstructive sleep apnea. So go in there, have fun with it, right? I put that in there for fun. I know you guys, hey, who couldn't use some fun, right? Let's go down. Many patients with sleep apnea are not obese, right? Just because you see someone that's not obese does not mean they do not have obstructive sleep apnea, right? So don't think that just because someone's skinny, or because someone doesn't have a lot of adipose going on, that they couldn't have this. In fact, one of my patients, when I was doing a clinical for a sleep, they were I think they were a triathlete, or they were they were a very highly trained athlete, and so one of the issues they had is their sleep. They would never feel rested after they slept, and so when we did it, sure enough, that patient had an obstructive sleep apnea. So their muscles, no matter, it wasn't due to the weight of their neck or anything like that. It was the muscles that were just obstructing, that were just releasing and obstructing. And so just because someone doesn't have a high BMI does not mean they do not have it. All right, signs and symptoms of obstructive. They will say, or their significant other will say, they have loud snoring. Yes, very, very loud snoring. That might be causing troubles as well. Observed episodes of breathing. Does it ever look like they stop breathing during sleep, right? Abrupt awakenings, we already talked about that. Difficulty staying asleep, right? That's where their brain wakes them back up because their brain says, I need oxygen to survive. Their heart says, I need oxygen to survive. And if you're going to fall asleep and deprive me of oxygen, I'm not going to let you fall asleep, right? That's that difficulty staying asleep. Their brain will literally say, do not go into a deep state of sleep because I need to stay alive. Moodiness and irritability, that could be for a lot of different things, but yes, absolutely, we talked about that restoring of the brain that happens with your deep stages of sleep. That cannot happen here because their brain's not letting them go into those deep stages of sleep. Lack of concentration, oh heavens. Memory impairment, I forget about that one. Little joke. Awakening with a dry mouth or sore throat, right? That's all that vibration. Morning headaches, especially with hypoxemias. Nausea, excessive daytime sleepiness, hypersomnia. In other words, they feel like they fall asleep at a stoplight, things like that. Intellectual and personality changes. Of course, they're going to have more emotional sensitivities to the things around them, a lot less peace in their life, unfortunately. Depression easily goes along with this, and this is why I'm so adamant about this with obstructive sleep apnea, with COPD patients, and looking for things like sleep apnea or sleep-related disorder with them, is because there's already a huge issue with depression in that patient population to begin with, and if we can make this one little tweak, that can make a big difference in someone's life and the life of those that are around them too. So don't ever rule this out. Nocturnal enuresis, you can look up what that is. I already know what that is. And they could have sexual problems as well as night sweating as part of this as well. So what are some risk factors for obstructive sleep apnea? Excessive weight's going to be high on that list. And one of the things they look at, and you can look at those scores under the Resources Center once again, is actually looking at neck circumference. So if you know your necktie number, which a lot of guys these days don't, I do because I love bow ties, but that's a whole separate thing. You can actually look at your necktie number and sort of know if I'm less than this size on my necktie or my collar number, or if you wear collared shirts that have that number, right, then you know that you are a higher risk or not. So neck size, hypertension, right, high blood pressure, just an anatomic narrowing of the upper airway. So let's say we had a kid, right, that had large tonsils and adenoids. Is it possible that a kid could have obstructive sleep apnea? Absolutely, right? Does that kid snore? Do they have mood issues? Do they have trouble concentrating? Right? All these things can form together to actually show that that kid probably that is diagnosed with ADHD actually might not have ADHD. They might actually have obstructive sleep apnea. They might have a sleep apnea issue that's causing their other problems that's going on. So just something that's out there. And your book has a lot more information. Like I said, your Wilkins book has a good sleep chapter as well, if you're interested in this whole situation. I love this stuff. Where are we at? Narrowing of the upper airway, we talked about tonsils and adenoids. That could put a factor. Chronic nasal congestion, a lot, especially people with allergies. Doing nasal rinses at night might help with some of those patients. Of course, consult your doctor. I'm not a doctor, right? Diabetes, of course, more common in genetic males. If you're older than the age of 65, I just said older than the age of 65. I didn't say old. I said older than 65. So if your age is greater than 65. Let's go with that one. Menopause, family history of sleep disorders. If you do a lot of alcohol, sedatives, and tranquilizers, sounds like a night before an exam thing. Please don't. And then, what's this last one? Smoking. Yeah, smoking's going to be on there too. Heavens to bed. Alright, so those were obstructive sleep apnea. Now we're into central sleep apnea. Central sleep apnea, this is where your brain says stop breathing. So there's no respiratory effort, there's no airflow. Okay? Remember, obstructive sleep apnea says there's respiratory effort, but no airflow because something's obstructing it. So central sleep apnea, no respiratory effort, no airflow. Central sleep apnea, no respiratory effort, no airflow. Central sleep apnea, no respiratory effort, no airflow. Okay, hopefully you got that down. This is where they'll have the stop of respiratory effort, and usually this can be a known or an unknown cause, so it can be idiopathic or unknown. It's also called secondary, so primary and secondary are some subcategories of central sleep apnea. So secondary usually includes Cheyne-Stokes breathing, and this is more common in your CHF patients, absolutely, and that's going to be a big issue. Do they have an underlying cardiac issue to begin with, and their heart, because they get hypoxic at night, gets put under more stress, and therefore can actually make their blood pressure and their hemodynamics worse. Yeah. So Cheyne-Stokes breathing is more associated with the CHF patients. Encephalitis, where the brain's swelling, anything that's including spinal cord injuries, spinal surgeries, hypothyroidism, drug abuse, all those can be part of essential sleep apnea. Even this whole thing of high altitude periodic breathing. So this means if you normally live at sea level and you go to Vail, right, to go for a ski trip at Vail, right, assuming that happens again, go to a ski trip at Vail, you're actually going to have a worse night of sleep up there because you're going to have your high altitude periodic breathing. Your body's not acclimatized to that environment, and that's why babies, even at high altitude, babies that are perfectly healthy, born at term, actually get sent home on oxygen because their bodies haven't acclimatized to the altitude yet either, right? They haven't produced more red blood cells. Their body's not acclimatized to it. So it's just something that you might see there. So that might actually cause cessation of airflow as well with a significant change of altitude there. So you can either have hyperventilation-related CSA or hypoventilation-related CSA. Hyperventilation-related, I think we go into it on the next slide. Yes, we do. All right, hyperventilation-related is most common, and that's the one where you have respiratory alkalosis, so they hyperventilate. Right, they've seen a ghost. That's a classic example I always use. Right, they hyperventilate. And what happens when you hyperventilate? By definition, hyperventilation means you get rid of a lot of CO2, which means you get more alkalotic, right? So your brainstem now has a lot of alkalosis. So do you think your brainstem's going to tell you to keep breathing? Or do you think the brainstem's like, stop it, you're alkalotic, so I'm going to stop you from breathing so you can retain some CO2 and get your pH back in balance again, right? So that's what it does. The pons and the respiratory center and the brain, right, the DRG, the VRG, all those good guys start going together, and they're like, okay, you're alkalotic, we're going to stop this for a little bit, and until you reach a point where you need to start breathing again. So this is where hyperventilate, and then you get so alkalotic that your body will just stop. Pretty crazy, right? So this is more recurrent, and then they get they go into essential apnea. Then they get hypercapnic because their blood's got to build up into more of an acidosis, right? And then they're gonna have an issue where their brain's like, oh, you're acidotic. Guess what? I'm gonna make you breathe really fast and really deep to get rid of this. See this vicious cycle? They hyperventilate, then don't ventilate. Then they hyperventilate, then they don't ventilate. Then they hyperventilate and don't ventilate, right? Usually it's a secondary problem, most likely a CNS disorder, right? And these are where, if you work in a neuro hospital or spinal cord injuries, this is where you might see it. Also occurs with drugs, different types of medicines or things like that, alcohol, opiates, barbiturates, benzos, tranquilizers, all these can actually be part of that as well. Neuromuscular, hey, Guillain-Barré, myasthenia gravis, go figure. It's almost like I have you guys do this in order for some reason. So those are some neuromuscular things that you could see that cause this issue as well. You can also see COPD and pulmonary fibrosis patients might also go into central sleep apneas as well. Here's the thing with this. The wakefulness stimulus to breathe and the results of alveolar hypoventilation occur, and they don't have that wakefulness stimulation that you see with obstructive sleep apnea. So they're not going to usually wake themselves up with this. They'll just have that weird breathing pattern. So that's what makes it a little bit more dangerous. Their body won't wake themselves up. At some point it'll breathe fast again, but it's not going to wake them up. That's still very, very bad because you have both hypoventilation and desaturation, which are not good for your body. All right, so we went over obstructive sleep apnea. We went over central sleep apnea. Now we'll go over mixed. Now remember, a mixed starts as a central and moves to an obstructive apnea, right? So this is a combination of both of them. So it begins as a central apnea, followed by the onset of respiratory effort, and there's no airflow still. So here's the situation. Let's say they got up here, we'll say this top line is airflow. So we'll just do airflow. And then let's do purple. This bottom line is respiratory effort. Okay, so when we're looking at airflow, so we'll start with, I'm just going to draw a line down the middle. A central sleep apnea, you start with the central sleep apnea. So there is no airflow, and there is no respiratory effort. You don't see anything moving. And then once this period is over, their diaphragm's going to kick in and be like, oh, you need to breathe, right? So they're going to breathe really deep, but guess what? There's still no airflow till eventually air starts moving, right? So this is where it starts off as a central and then it goes into an obstructive. Because remember, with obstructive, you have respiratory effort with no flow. So that's where it starts off central, where there's nothing on either of these. Then it goes to obstructive, where there's nothing on the flow, but there's respiratory effort. So this is a classic sign. This whole thing together is a picture that you'll see on their tracings. This is something you'll see on their tracings that we're looking at, and that is a sign of a mixed sleep apnea, right? Most of these patients are treated as having obstructive sleep apnea. The idea here, if we stent open their airways and give them that flow through their upper airway, they'll be able to not only oxygenate, but to ventilate better as well, even though it's not a ventilation device. So we're helping wash out dead space, and therefore helping their brain sort of see this and avoid this hyperventilation part that you see on the obstructive side, right? And this is the picture. This is much better drawing than what I can do. And this is one I took directly, probably from your book, most likely. And this is looking at airflow patterns, respiratory patterns, and they just added the oxygen saturation part to this. So in all three of these patients desaturate. So if you're looking down at the arterial saturation down there, they desaturate. So the esophageal pressure is looking at respiratory effort. So they put in esophageal pressure monitoring on these patients. Oh heavens. And then they put in airflow, which is just an external transducer that we use, right? So with the central apnea, you see no airflow and no respiratory effort. And as a result, they desaturate. Obstructive apnea, you see no airflow because their airway is obstructive. You see respiratory effort. You see how it's that crescendo, right? You see how it's getting deeper and deeper and deeper until finally there's airflow that goes on here. right? Same thing here, they're still going to desaturate as well. Mixed sleep apnea, it starts off as a central, and then it goes into an obstructive. So you see how this one is a combination of both of these. Hopefully that makes a little bit of sense. You'll still desaturate. So let me ask you this. We put a nocturnal pulse ox on someone, and we see that they desaturate. Can you tell, just by their pulse ox, if they have central, obstructive, or mixed sleep apnea? Good question. Maybe you'll figure it out. All right, so we're getting there, I promise. So sleep-related hypoventilation syndromes, we talked about this on that opening, one of the opening slides there. This is a broad range of things, and this can include OHS, obesity hypoventilation syndrome. Don't ever rule out OHS on these patients. They'll be under a lot of cardiac stress, a lot of hemodynamic issues, a lot of poor sleep issues, usually a lot of poor social issues as well, because remember, it affects their grace. It affects their ability to relate well peacefully. I don't know a good way of saying this. So Pickwickian syndrome, OHS, is sort of the same thing. COPD is called crossover syndrome when you have something like COPD and you have sleep apnea related, and that means that you have both issues going on at the same time. Like I said, this is something that you should keep in the back of your mind even if you work in acute care. Congenital central hypoventilation syndrome and neuromuscular chest wall disorders can also relate into this. More common in kids, I think it's called Ondine's curse. You can go look that up. We don't have the time in here to do that. Ondine's curse. All right, go look that one up. Neuromuscular and chest wall disorders, we talked about that with Guillain-Barré. Myasthenia gravis could easily go into this as well. Abnormal gas exchange that can happen during sedation. Of course, conscious sedations, when you guys do those in the emergency department or anywhere else in the hospital, when you undergo those conscious sedations, you can easily have an issue where the patient hypoventilates and you might have to assist their ventilation. We'll talk more about that in critical care techniques as well. Usually hypoventilation, they get hypercarbic. The diagnosis of crossover syndrome is missed in a lot of critically ill and hospitalized patients because they assume most of it is pneumonia or something else that's causing the issues. Diagnosing these patients usually begins with sleep evaluation. So they might just do a nocturnal pulse ox and see they desaturate, and then they want further information, so they might order a formal PSG, a polysomnography test. Usually they'll look at the history. Of course, they'll do the stop bang score or the poor sleepiness scale, right? Those things that are included in the resources. Right, so they're going to look at those things. They might actually look at the upper airway. They might have them follow up with an ENT doctor and see if there's like something in their throat that's swollen or something like that going on. We might actually do a bedside flow volume loop on these patients and see if they have variable versus a fixed upper airway obstruction too. So that's something that we might be looking for as well. So polysomnography is the formal sleep study as well. And of course they can do blood tests. Let me skip that over. They can do blood tests to look for polycythemia or thyroid issues, as well as higher bicarb, serum bicarb levels. And a lot of times these can be done in home, these sleep studies. They're not as high quality as a sleep lab sleep study, but they can still give you the general idea of what type of sleep apnea is going on. So polysomnography is the formal sleep study of PSG, and this is the sleep test that records all these different patterns, where like I said, it has all these different electrodes, all these things all over the place, and we can see very detailed what's going on. They can do that all night long, and then you'd have to come back for a therapeutic one to determine what's therapeutic, or they can just do what's called a split night. So this is where the first part of the night we diagnose that you have obstructive sleep apnea or whatever it is. And then the second half we're going to give like a CPAP, right? And this is so we can titrate and know, okay, you do have obstructive sleep apnea, and this is what level of CPAP you're supposed to wear that will treat it. And so that's what is usually more common as of recording this out there, is that split night. And that CPAP, like I said before in that one of the early slides, is just to help stent open the airway. when we're looking at this. Sleep study, when we're looking at this, is we have 15 or more apneas, hypopneas, or respiratory effort-related arousals, RERAs, right? And then one of the things that we're looking at, and it's in bold here, is the respiratory disturbance index greater than 15 events per hour. So that's something that we'd want to keep in mind before CPAP and after CPAP. So what stages of sleep? Now these are real quick and you'll have to go over these in advanced diagnostics. So you might as well get a good idea here is N1, and these are good sputable question areas. N1 is where you're sort of just relaxed. You sort of don't know that you're drifting into sleep, right? You're just in that sort of meditative zone there. Your heart rate and your blood pressure drop a little bit here. If you're awake, you might say that you're not asleep, you're just, relaxing on your chair, right? So that's N1. So N stands for non-REM. So non-REM stage 1. Then you have non-REM stage 2 or N2, where your heart rate and your blood pressure, all those things, your temperature, they all start to decrease a little bit. So that means you're sort of drifting off. If you woke up, you might say you were in like a deep daydream. You were just sort of in a light nap type situation. N3, the older you get, unfortunately, the less N3 you have. Heart rate, blood pressure, and respiratory rate, body temperature, and oxygen consumption will continue to decrease because you're going into that relaxed, restorative state here. You can dream in N3, but these people are usually harder to get out of their sleep, so they'll be not as responsive if you are trying to interact with them. And finally, REM is your final stage. This usually doesn't happen until about 90 minutes into your sleep cycle. And usually you'll see the EEG pattern change to more an aroused state, but their body is not in an aroused state. So their brain is active, but their body is paralyzed, so it doesn't act out the dreams, right? And this is usually your dream stage of sleep, most commonly. So the EEG will, like I said, will look like they're awake. Their respiratory rate is going to be variable. Heart rate and blood pressure are going to go back up because now they're in sort of this dream simulation scenario. And hopefully their muscles are paralyzed. Not like paralyzed where they can't breathe, but paralyzed where they can't act out their dreams. Like I said, sleep medicine is super interesting, right? We'll have PLMs, we'll have all these other things that can happen here. I mean, if you're talking insomnia, sleepwalking, things like that, super interesting stuff. So please consider this as a good, valid area to go into as well. Most dreams will occur during REM sleep, but take a guess. Which stage of sleep do you think, especially with muscle paralysis overall, is most likely to go into sleep apnea, right? More likely the REM stage. And so that's why some of the CPAP machines out there, we can set a ramp feature where you can start off on a CPAP of 4 or whatever it is, and then and set it to 90 minutes, and at 90 minutes it's at their therapeutic level of 7, let's just say. So that way they don't need that CPAP right away because they're not in that REM sleep right away. We can actually titrate it for when they do need it for the level they have, and that way they're more compliant with wearing it at night. All right, so what do these patients look at the bedside? Well, the apnea should give it away. Hypopnea should give it away. And cyanosis should give it away. But the big thing you might see, especially if you work daytime, is they'll have excessive daytime sleepiness. They won't be able to hold conversations with you no matter how interesting you think your respiratory lectures are. They won't be able to hold concentration with you. That's pretty sad. X-rays on these patients usually are normal. If it's chronic and it's been going on for a long time, you might see more right-sided heart failure. Remember, it puts a lot of stress on the heart. So pulmonary hypertension can easily go along with this, especially if it's a chronic issue. Usually you can see enlargement. It might help to rule out a sleep disorder when they do see cor pulmonale. PFTs on these patients, decreased volumes, of course. These patients aren't getting good volume of gas into their lungs because there's something stopping the gas from getting into their lungs, right? It's restricting the amount of gas that can get in there. So this is going to be restrictive as far as that goes, right? So they're more likely to have atelectasis, more likely to be hypercarbic because there's something blocking the airway. So remember when I was talking about a PFT and we could do a flow volume loop to look at this? Patients with obstructive apnea may show that sawtooth pattern. You see how squiggly those lines are there, right? You see that little arrow pointing to that squiggle? Right, so that's something where you're looking at how much gas is flowing through there and how variable that flow is. So that's something where we can actually see the airway is floppy. The airway has an ability both on the inspiratory and expiratory loops on this flow volume, right? The inspiratory is down here. The expiratory is up here. Inspiratory, if they have this going in, that means there is something that their airway is loose. It's fluttering. It's obstructing their airways, so that way gas cannot flow easily in there. So they might have you do a bedside flow volume loop on these patients, and that might be a visual indicator that obstructive sleep apnea could be what's going on. Will it diagnose them with obstructive sleep apnea? No, but it could give us the indication that we could do further testing. ABG, it's going to be chronic or compensated respiratory acidosis in these patients. So you would draw blood gas, do a Q morning blood gas on these patients like right after they wake up, and then it would show compensated or chronic respiratory acidosis if it's severe enough. Oxygenation, this is going to be a shunt-like pathology because you have perfusion, ventilation. Remember, we're hypoventilating, so we have perfusion without ventilation. So by definition, it's a shunt. Decreased DO2 because our CCO2 is decreased, right? Because we're hypoventilating. Therefore, our CaO2 is going to be decreased. Therefore, our DO2 is going to be decreased. Consumptions, VO2 and A to V gradient, normal, right? Not a hypermetabolic issue. OTR is increased because we start off with the lower DO2. SVO is decreased because we start off with the lower DO2. Hemodynamics, right-sided heart pressures. CVP, right atrial pressure, mean pulmonary pressure. Right ventricular stroke work index and pulmonary vascular resistance are all increased. When we're looking at the left side of the heart, cardiac output, stroke volume index, cardiac index, left ventricular stroke work index, and systemic vascular resistance. What do you see here? So cardiac output, stroke volume, we'll just say are normal. Stroke volume, cardiac index are decreased. The left side of the heart, is that working harder or less? Well, if that's an up arrow, that means it's working harder. So we know the right side of the heart is working hard. That's why we can see cor pulmonale. Is the left side of the heart also working hard? Right, left ventricular stroke work index means, yeah, it is working hard. And our systemic vascular resistance is also increased. So when we're looking at the left side of the heart, we can have some issues with the left side of the heart effect here, and some of this is going to be because of the cyanosis, because of the hypercapnia that's going on with hypoventilation. I hope that makes sense. So left-sided heart pressures can be affected by this, right? So we're not looking at cardiac output or stroke volume necessarily. The heart might be affected to the point where it could actually drop the stroke volume, how much is being squeezed out in the stroke volume index, how much is being squeezed out, or the cardiac index, how much is being squeezed out, because the left ventricle is working harder. So you got to be careful with this. Systemic vascular resistance will increase, especially if they're hypercarbic in that situation, or hypoxic. Therapeutic interventions for sleep-related breathing disorders. Behavior modification, of course, if that was something every patient did, that would be amazing. But weight loss, sleep position, we already talked about sleep position earlier on. No alcohol before bedtime. I know. You're like, Derek, you've never been in respiratory school. So when we're looking at all these, you're looking at behavior modification being one of the most non-invasive ways to do this, however, not a very common way that people usually resolve it. Positive airway pressure, we talked about that with CPAP machines. Stenting, open the airway, that positive airway pressure just sort of keeps the tongue from flopping back down into the airway. Oral appliances, this is something that a dentist or one of those specialists can make for the patient. It does pretty much a modified jaw thrust from the way I understand it, and therefore sort of keeps the tongue from flopping back into the airway. Surgery, they talk about TNAs, tonsils and adenoids removed. They can do the UPPP, uvulopalatal pharyngoplasties. We talked about that in pulmonary A&P. Implantable airway stimulator, like I said, Inspire with an I. Go look at that website real quick. They have little videos on that. It's pretty interesting how that works, and it just sort of, like I said, gives stimulation to those muscles for when they sleep, and it sort of keeps the airways open. So go do that. It only takes, that video I think is like maybe less than 2 minutes, where they explain it and sort of show the animation and stuff. And then finally, oxygen therapy, just nocturnal oxygen in the meantime. We might have to give them, hey, 4 liters at night and 2 liters during the day, just in the meantime, so they don't get hypoxic. All right, review questions. What are the common forms of sleep disorders? What might you find at the bedside evaluation? What are some things that you might see on these patients? What would their chest x-ray look like? Especially what cardiac signs might you see with someone that had chronic severe issues? ABGs. What would their ABGs show if it was severe? Oxygenation. What type of, is this shunt? Is it dead space? What happens with their CaO2? What happens with their CCO2? What happens with their O2-ER? What happens with their VO2? What about their PFTs? Is this obstructive or restrictive overall? Do they have low volumes and it's an obstructive disorder? Or is it restrictive? Sorry, do they have low flow rates and it's an obstructive disorders? Or is it restrictive and they have low volumes? Remember, what's happening to the airways? Are they getting low volumes or are they getting low flow rates? What stages are they most likely to have sleep disorders? In other words, what stage of sleep, REM or non-REM, are they most likely to have sleep disorder issues? I want you to think deeply on that one. Hint. What are some therapeutic interventions you use for sleep disorder breathing?